So I know we just spoke for a while at length about the future of Enriched, but I'm actually going to start with a look back, my personal history of Enrich, and some funky stuff happening on my slides. That's going to be an interesting challenge, but I think we're going to go with it. So yeah, back in 2015 was my first introduction to Enrich. I was invited, I think by Jennifer. And it's around the time when there was a flurry of new methods related to mediation analysis, this kind of new causal framework for mediation in the epi literature. And so I was invited to give a talk about that for 45 minutes or something like that. I saw some other colleagues who were on that schedule too, very interesting meeting. And the story I'll tell today is actually kind of a continuation of that, because there we had kind of the new methods for thinking about mediation in the causal framework. And that's not to say that everything we get from those types of models are causal effects. It's just trying to make clear what are the assumptions necessary, right, to draw a causal inference from those types of analyses. And I'd say in the last 5 years, and what I'll talk about more today, is there's been a growing interest in applying those methods for looking at social inequalities in health. So how can we try to understand some of the intermediate pathways and potential targets for intervention to mitigate social inequalities in health? So I'm going to draw on some of that more recent literature today. So it was kind of fun taking a look at these photos on the website. I found myself standing in the back right, just like I was yesterday, without really thinking about it. So I always gravitate, I guess, towards the back right. So I won't spend too much time on background. This group definitely knows this background better than I do. I'm not an expert in child undernutrition. It's kind of a new interest. But of course, it's very important when thinking about population health, specifically for low and middle income contexts. And I wanted to recognize that next year, 2025, is the kind of end of the bookmark for the UN Decade of Action on Nutrition. And there were many important goals that were set forth for that decade, as well as for 2030 with the SDGs. And by 2025, some of the goals included reducing stunting by 40% globally and reducing wasting to 5% globally. And this has important implications I want to draw over the life course, because when we think about social inequalities in child nutrition, and this is part of my interest in these outcomes today, we can see evidence of those inequalities right from birth. And they're transmitted over the life course because they then have impacts on not just health outcomes, but also social and economic outcomes over the life course. So unfortunately, to kind of go back to the second half of Dave Gordon's remarks from yesterday, there's progress, but we're falling short when it comes to meeting those goals that were set forth for 2025. This is not current data, but the most recent I could find, looking across many different low and middle income countries. And Gonzalo did a nice job of talking about the DHS and mix, and many of these analyses that are kind of looking at the prevalence or social inequalities in undernutrition across LMICs are using data from the DHS and mix. They're the best source for comparable measured information on heights and weights for children under 5. And you can see that the stunting prevalence across LMICs was about 30%, and globally about 150 million children under 5 suffered from stunting in 2020, compared to the goal that they're hoping for by 2025 was to reduce that to 100 million. For wasting prevalence, it's around 6.3%, and in 2020, about 45 million children under 5 were affected by wasting. And the underweight prevalence was around 13.7%. As with many of these types of questions, you're going to find a multitude of different conceptual frameworks talking about the hierarchy of factors that affect them. This is one from UNICEF, and just kind of drawing your attention to the fact that there's kind of these more distal enabling determinants, kind of macro level determinants, these kind of underlying determinants of maternal and child nutrition related to food behaviors and also access to health services. And then of course, these more immediate determinants related to healthy diets, dietary diversity, but also avoiding the incidence of illness, right? And you could draw across many of these. I like this one from Professor Buta that was published in 2020. A very similar kind of framework thinking about underlying drivers, the social determinants. I guess you can't really, oh, can you see? Oh, there you go, oh, nice. These kind of meso-level determinants here. And again, the more immediate drivers of child stunting, in this case, looking specifically at stunting as well. And there's a bunch of papers out there now which have used similar data sources from DHS and MICS to measure inequalities in these outcomes, stunting, wasting, underweight, across different social dimensions. So basically look in the relation between a social determinant of health and undernutrition. So this is looking across 98 countries for which there was comparable data, again, using DHS and MICS. And if you just want to draw your attention to stunting, you can see evidence of pretty clear social inequalities in stunting across these different dimensions. So this is the gap between rural urban, so stunting prevalence around 35%, in rural areas around 25% in urban. And oftentimes when you use DHS and mixed data, people look at households SES as measured by the wealth score, which is based on an asset index. So that's reflected here, looking at the poorest quintile based on the index, where the stunting prevalence is around 43%, versus the richest quintile, where it's about 18.6%. So clear evidence of social inequalities in child undernutrition across LMICs. I think if you kind of got anything from that slide, I think that's the main point. And this raises a lot of questions about how to then address those inequalities. And I think there's a couple of different ways of thinking about it. One, I think, would be to actually intervene on the social determinants themselves. And we heard many interesting conversations about that, going back, for example, to Dr. Pickett's talk from yesterday. An example of that would be universal basic income, right? If we're looking at an inequality in child undernutrition by poverty or wealth, we could actually intervene on that social determinant to address that inequality, right? And I think that's also consistent with Professor Ahun's talk about cash transfer programs, right? If you see income or wealth-based inequalities in an outcome, right, you can think about an intervention or policy or program in that case that directly addresses that social determinant of health. But another way to think about it is to start thinking about the different mechanisms, right, or intermediaries that link social determinants to child health outcomes. And so that's a separate kind of question, which is like, rather than intervening on the social determinant, I'm now going to start intervening on those intermediaries and closing those paths and seeing if that has an impact on the magnitude of the child health inequality. So one of the challenges is thinking about different interventions which we could hypothetically intervene upon. And there's been some more interesting kind of recent work on this. And the idea here is, looking forward, is one of the conclusions from this paper, greater effort is required to improve intervention coverage, especially for the most vulnerable, to help to redress those inequalities. This is another framework for thinking about different types of interventions for affecting child undernutrition. I'm not going to spend too much time on it, but one of the kind of key points from this one is that you can look at interventions both within and also outside of the health sector, and also those that are nutrition specific versus what was formerly called nutrition sensitive, but things that are kind of more within the realm of social determinants. So if you look, for example, at direct health sector nutritional interventions like these, you can think about support for early immediate breastfeeding initiation, delayed cord clamping, immediate skin-to-skin contact as things that could affect the prevalence of child stunting. And you can also think about things that are more upstream. So here in this case, women's empowerment and water, sanitation, and hygiene types of interventions that are outside of the realm of the health sector and not nutrition specific, but these could also have an impact on the prevalence of child undernutrition and also social inequalities in those outcomes. So a paper by Heidkamp in 2021, which was reviewing some of the evidence on potential interventions, and they used a decomposition method, which I'll come back to a little bit later, to look at interventions that have some promise for mitigating social inequalities in child undernutrition. And I just want to draw your attention to 4 Indian states, since I'll be kind of talking about Indian data in a few seconds. And 2 of the domains for potential interventions that were of interest and which showed promise were wash interventions, so water, sanitation, hygiene, but also what they refer to as maternal and newborn care. And they define that here as receiving ANC, so antenatal care, delivering in a health facility, and also delivering with the assistance of a skilled birth attendant. And those 2 factors seem to explain a substantial proportion of variation in child height for age, so referring to stunting here, scores across a variety of different contexts. And I'm going to focus on those two areas for the purpose of my kind of illustration today. So that brings me to my research question for today. Like I said, I want to kind of continue along this thread of mediation from 9 years ago. And the question I'm trying to ask here is, to what extent does intervening on two different types of mediators or interventions, maternal and newborn care, and also improved water and sanitation, to what extent does intervening on those mitigate social inequalities and undernutrition in India? And I will say that now that we're getting to the data, this is very much a work in progress, probably more so than I'd like to admit. So I'm very much looking forward to your comments, but they'll be very much appreciated. So I'm using data from the National Family Health Survey in India, which is basically the Indian equivalent of the DHS, but it's substantially larger than in most other countries because they provide district level estimates, district representative estimates for the 650 or 700 districts in India. And they're collected in basically the same way as the DHS. There's a multi-stage sampling procedure where they randomly select households per primary sampling unit. And within those households, they survey all women of what they define as reproductive age, 15 to 49, who were usual members of that household and ever married. And those respondents complete a women's questionnaire. And there's also questionnaires given to men and also a biomarker questionnaire that includes information on measured height and weight for children under the age of 5. So for this analysis, we included information from the NFHS rounds 4 and 5, which went from 2015-16 to 2019-2021. And that included about 500,000 children under the age of 5 who were born between 2010 and 2020. And yeah, I limited the analysis at 2020 to because there was a very small sample of kids relatively in 2021. Sorry. So how am I going to define these social inequalities in health? So what we've chosen as a social determinant is caste or tribe affiliation in India. So if you're unfamiliar with this, of course, India has a long history of social stratification defined along many different dimensions. And after independence in 1947, the government implemented measures to address this social stratification by designating certain groups as historically disadvantaged. And it did this with the purpose of trying to address these inequalities through different policies and actions, including affirmative action policies that would, for example, reserve slots in higher education institutions for members of these disadvantaged groups. So they've defined 3 different types of groups: scheduled castes, which are socially marginalized groups based on their occupational level; scheduled tribes, which are indigenous ethnic groups that have been socially isolated; and other backward castes or classes, which is a more recent grouping of disadvantaged classes. So we're grouping these together into a binary measure for whether or not the child comes from a household that self-identifies as being part of a scheduled caste, scheduled tribe, or other backward class. And membership in these groups is essentially assigned at birth and transferred intergenerationally, right? So for the outcomes, so I've kind of told you about the social determinants. For the outcomes, we're focused, of course, on child undernutrition. Like I said, heights and weights were measured in the DHS for all children under the age of 5. And we're using the standard binary measures for stunting, wasting, and underweight, which is less than 2 standard deviations for height for age for stunting, weight for height for wasting, and weight for age for underweight based on the WHO standards. And for now, these hypothetical interventions that I alluded to, the first one, like I said, is thinking about improving water and sanitation coverage in these households. And this is based on 2 questions that was asked in the household survey for the DHS. So one is based on the kind of toilet facility that members of the household usually use, and the other is the main source of drinking water for members of the household. And based on the DHS and other references, those are then categorized as being defined as improved facilities or not. And for the purposes of this analysis, we created a composite, which is whether or not the household had improved water and sanitation facilities, right? And the second potential intervention or mechanism was health facility delivery with a skilled birth attendant. We didn't have information on antenatal care for all children under 5, so we, in this case, defined it based specifically on health facility delivery, and also delivery with a skilled birth attendant, right? So again, to be coded as a 1, right, you had to be delivered in a health facility with a skilled birth attendant present. Okay, getting into some data now. So these are graphs showing the change in the prevalence by age for children under 5, stratified by the social determinant, which is whether or not the child is from a household that identifies as being part of a scheduled caste, scheduled tribe, or other backward class. So those households are in red. There we go. Okay. Those households are in red, and households that don't identify as being part of those disadvantaged groups are in blue. And you can see variation over the early life course. So you see a kind of rapid initial increase in the incidence of stunting with a peak around 24 months, which I believe is quite consistent with the literature, and then a leveling off. But, importantly, for the purposes of this question, you see this gap, which reflects the inequality or disparity between disadvantaged groups and less disadvantaged groups. Wasting prevalence is lower and seems to decline initially after birth and then level off. And for underweight, we see a slight increase in the first 24 months, which then levels off. But more evidence for a stronger, a larger magnitude of the inequality for underweight compared to wasting. I think you'll struggle a little bit to see this in the back, but I wanted to give you a sense for for some of the data and some of the descriptives and what the kind of population looks like. So maybe I'll just draw your attention to the main kind of covariates, including our social determinant, which is scheduled tribe, caste, or other backward class. So 82.6% of kids in the sample were from households that identified as being part of one of those disadvantaged groups. So it's quite high. When we then think about the mediators, right, so improved water and sanitation, that was 57.6% of households. And then for facility delivery with attendant, that was around 3/4, right? And then here's the prevalence of the outcomes of interest. So stunting, about 37%, wasting, about 20%, and underweight, about 1/3. Okay, so now we're going to get into some of the mediation discussion. So there's going to be a lot of arrows. I apologize. But prepare yourself. Yes. So here's basically the total effect of interest, right? So if we want to kind of look at the impact of intervening on these potential mechanisms, there has to be some evidence of a disparity to begin with, right? So this is kind of measuring that disparity between membership in a scheduled caste, tribe, or other backward class, and our outcomes of interest, which were stunting, wasting, and underweight. And so we're just kind of basically run that model, look at the what's called total effect in literature, but we're not giving a causal interpretation to these. And in these models, we're just basically controlling for state and year fixed effects, because basically these characteristics, right, are assigned at birth. So we're not controlling for a bunch of stuff in these models. So that's how we're estimating the total effect. But of course, when we kind of look at this from an intersectional sort of framework or lens, there's many different types of social determinants that are kind of interacting and which might affect those outcomes of interest. So we want to represent those on our directed acyclic graph as well. So historical processes like the ones that I've kind of mentioned that have given rise to these socially isolated groups could also influence other social determinants like maternal education as well. And then here we've included the potential mechanisms, right? So intervening on these hypothetical intermediaries, improved water and sanitation facilities here. And we then want to kind of get into this discussion of, if we want to intervene here, how can we kind of decompose the total effect that I showed you here, accounting for some intervention on those mechanisms, right? So how do we do that? In literature, I think we'll find two very common approaches before, I think, this more recent introduction of causal mediation methods. One was Baron and Kenny's kind of product method, And what you do in this case is you'd estimate that total effect, and then you'd include the intermediary. So you kind of throw this into the model here, and you'd see if there's still evidence of an association between the social determinant and the outcome. And if there wasn't, that'd be some evidence that this intermediary was important. And there's a lot of caveats to that sort of interpretation. And the other one I think we see more commonly in economics is kind of a Blinder-Oaxaca decomposition, where you're trying to decompose that disparity or inequality, in this case by schedule, caste, tribe status, into some part that's attributable to difference in levels between factors, differences in the kind of effects of those factors, and unexplained part and the combination, right? The caveat I would say to both of these is that they can't be interpreted causally because they don't explicitly address confounding. And I would say specifically confounding that's affected by the social determinant itself. So I'm going to kind of illustrate that here. So like I said, there's many other factors that might be affected by your exposure of interest that also are related to your mediator and also your outcome. So thinking about household wealth, it's likely to be affected by social disadvantage measured by caste, tribe, or other backward class, and related to these mediators, as well as the outcomes. And once you've got this set up, you're kind of stuck with when it comes to traditional methods, right? This is kind of now going back to my 2015 remarks, which I'm sure you remember very well. You can't just control for these factors because you're then blocking another pathway between your exposure and your outcome. But you can't not control for them because when you then control for your mediator, you could actually be inducing a selection bias, right? That's kind of the short end of it. So traditional methods kind of fall apart when you've got this kind of setup. And I would actually argue that almost any time you're looking at social inequalities in health, you're going to have exposure-induced mediator outcome confounding. I think it's almost always going to be the case, right? So I would strongly encourage people not to use those methods and give it a causal interpretation. So here we can then separate the total effect into the direct part and also this indirect part. And what we're going to do is apply methods from the causal mediation literature and estimate the average causal direct effect. So what we're going to do here is basically compare children from households that identified as being part of a scheduled caste or tribe to those that didn't. And what we're going to do is intervene on the mediator and set it to 100% coverage for all of those families. So we're going to set improved water and sanitation to 100% for all of those families. And we're going to set health facility delivery with a skilled birth attendant to 100% for all of those families and see what impact does that have on the degree of the social inequality. Like I said, we can't just control for those factors, so we're going to use weights. So in this case, inverse probability weights, and we need two weights in this case, one to deal with confounding of the total effect, and the other to deal with those confounders of the mediator outcome effect. And the beauty of this versus kind of regression adjustment is that we're not controlling for these factors. We're just going to be waiting for them, which then circumvents that issue of the selection biases that I mentioned. So very quickly, because I think I'm going over time here, I wanted to show you basically how this looks to give you some confidence that things are working properly. So in the unweighted sample, when we're looking at families or children from families with improved water and sanitation versus those that are not improved, we see huge imbalances in terms of covariates that might be related to undernutrition, right? So for example, the wealth index score is much higher in households with improved water and sanitation versus those that are not. So this is kind of what we'd expect, right? This is not randomized. And so the average standardized mean difference is about 16.9, which is quite high. And on the right side, we see the results from the weighted analysis. So we've kind of constructed those weights for the exposure, for the mediator, we multiplied them, we reweighted the analysis, and we see that we've achieved, I guess, what we call conditional exchangeability, right? Good balance in terms of these measured covariates across those two groups, right? So this is like effectively randomizing the mediator on measured characteristics. All right, I'm just going to conclude now with two summary slides with the results so far. Like I said, these are kind of early on. The total effects are on the left side here. So These are just basically a measure of the disparity comparing children from households who are members of scheduled tribe caste or other backward class versus not. These actually should be prevalence differences. And we see for stunting, it's about 8.6, for wasting 2.7, and for underweight 8.1, which seems pretty consistent with the graphs that I showed you. When we use the traditional method that I mentioned of just kind of controlling for the mediators, we see huge reductions in those disparities, which suggests that a lot of that is explained by these characteristics, or at least that's the way people used to interpret these things. However, when we then use the newer approaches, the kind of marginal structural modeling approach where we're weighting rather than adjusting, we see actually not much evidence of mediation by, in this case, improving water and sanitation coverage to 100% for all households. So whereas there was kind of a 50% reduction in the disparity in the kind of product method approach, it goes back to zero actually when we use the marginal structural modeling approach. For wasting, there was a smaller absolute effect, and actually the results are quite consistent across the two methods, and we see a very modest reduction in the total effects using the weighting approach. So maybe some slight evidence of water and sanitation interventions being important here. And this is a very similar slide, but showing the results for health facility delivery with a skilled attendant as the intermediary here. And the story is very similar, actually. We see, of course, the total effects are the same, large reductions when we use the kind of regression adjustment method. And a lot of those are closer to zero, right? Except for the case of wasting when we use the weighting approach. You might be scratching your head about how this is negative, but I think this shows you how complicated looking at social inequalities can be. So when I looked at the predicted probabilities for these, what happened when we assigned 100% coverage for health facility delivery to both groups, so scheduled tribe caste, other backward class versus not, is that we actually saw a reduction in the prevalence of stunting for the disadvantaged group, but not for the advantaged group. So actually there was an increase in the inequality as a result of that. So it's kind of these, we see a reduction in the level overall, but actually increase in the inequality, which I found quite interesting. So very provisional conclusions here. We've assessed the impact of intervening on two potential mechanisms that might link social inequality, social determinants to child undernutrition in India. We compared two different methods. They provide quite different results. I think we have a lot more model checking and sensitivity analyses to throw at this. But so far, there's some evidence that these interventions have a modest impact at reducing social inequalities and wasting. Thank you.